Hello, everyone. This is Debrief for case 3. Good job, everyone. I've heard a lot of good things from the facilitators, and I get the opportunity to facilitate myself this week for case 3. So I've seen a lot of growth, and I've heard a lot of growth, improvements from everybody's session. So I'm very happy to hear about all of the positive things from the facilitators. So again, I'm gonna go through a few things. Just want to share. Since you guys did so well this week, I don't have much to say for this debrief, so hopefully I'll keep it short and sweet. So for the therapeutics part, I just want to reemphasize again, just based on different comorbidities, disease states, specifically for the opportunistic infections and HIV. And I heard that everybody mentioned about the delaying the antiretroviral therapy in the setting of the opportunistic infection because of the iris risk. So I just want to emphasize it again, just because it can cause some harm if we don't delay it. Similar thing, in the future, if you have any comorbidities, disease states that might be acute, and like something to kind of watch out for is like some medication you might have to delay or like postpone a little bit until the patient's got stable. So in this case, in the setting of OI, you don't want to start the antiretroviral therapy. And then there's also the OOB questions about the insulin, being converted in the inpatient setting, just because we don't have the hospital formulary doesn't have the insulin NPH, so you have to convert it to glargine. I've some students were able to sort of like just convert it, from insulin NPH to like glargine. That's great that you are recognizing, you can convert it instead of kind of just using the insulin dosing from, the basal bolus protocol. I'm going to talk about it in the clinical pearls later on, but the insulin conversion guide, I'm sure like when you Google insulin conversion, which you guys did probably to get the conversion ratio, the most top, like links that you will get is probably the pharmacist letter. And the guideline is very, very helpful in the inpatient setting, especially. And in the inpatient setting, a lot of times, patients is going to be on different type of insulin. Nowadays, we have a lot of brand of glargine, like, Lantus, Basaglar. There's also like different long-acting insulin or like intermediate acting, where, you might make sure that, you convert it appropriately to prevent overdose or underdosing the patients, okay? And just kind of want to remind you guys about blood glucose control in the inpatient setting. So you would like to know what kind of goal blood glucose, right, that you have to target while the patient in the inpatient setting. It's not going to be similar to what you have in the outpatients, just because they are their condition is not going to be the same while they're in the inpatient setting. They're going to be at higher risk for hypoglycemia. So if you look at the guidelines, it's recommended to maintain the glucose in the inpatient setting between 140 to 180. So that's, I would say, a little bit more lenient than what we have, for the blood glucose target at home, right? Because if you're trying to reach some kind of blood glucose goal in the outpatient setting, you have the fasting blood glucose goal, which is between 80 to 130. And then anything, prandial, postprandial, you want to target below 180. So there's like difference of goals of blood glucose in regards to outpatient versus inpatient setting. So it's just kind of keep in mind in terms of that goals and the difference, and why we are doing different goals, right? So that you can kind of kind of assess in terms of what kind of dose that you want to give for the insulin in the inpatient setting versus outpatient. For the DDI screening, definitely with your antiretroviral therapy, as you probably learned in your HIV lectures, there's a lot of drug interactions with most of the antiretroviral therapy. So definitely at the end, which I believe everybody's doing, since you guys did well with, recommend adjusting other medication. You have to go through the drug-drug interaction screening. All right, and not only just for HIV, right? You have to kind of think about other therapies, that might be their home medication, which, a lot of you guys are already doing screening with the statin, and also the inhalers that she's taking. But also kind of think about the new problems, new medication that's going to be started, right? Your antibiotics, because now, with the fluconazole, with the your what do you call it, the vancomycin, or like the antibiotics that she was on, I know, like, a lot of you guys are going to discontinue the antibiotics and acyclovir, but like there's more new antifungals that are being started, right? And also your neuropathic pain planned. So don't forget about the new medication that you're going to be starting. You have to think about how, if there's any interaction with the new medication, not just the home medication. And then lastly, the duloxetine starting dose. If a lot of you guys, I heard you guys chose Simtuza for the antiretroviral therapy, and as you've probably seen from working out the patient, there's a lot of interaction, and that includes the duloxetine. I know that it's only category B, so not as high as category D or X, but there is still potentials for interaction, right? So when you're starting something, you want to kind of weigh in terms of benefit versus weight, right? Versus the risk. So what is the risk of patients getting, certain dose versus, lower dose, if you started, and what is the benefit, right? So in this case, for the patient, the benefit of the duloxetine is to sort of provide relief for the pain, right? And the risk is, there is some, right? There's like a lot of adverse events with duloxetine, like hypertension, and some SS serotonin syndrome. So there's like some risks associated with it, and included with the Simtuza, although the drug interaction category is not as high, there is the potential for direct drug interaction, right? There is still potential that the patients might get increased exposure of duloxetine when they don't need it, right? So it's recommended, like if you're starting something new, you could start something at lower dose, right? And the benefit, it's not like we are using the duloxetine for depressions or like other mental health disorders, because that takes long to see the effect, right? In this case, it's for pain relief, so the onset should be pretty, faster. You will see it like faster than, more than 4 to 6 weeks with depression. So you can sort of titrate it quicker in terms of the, like having duloxetine for the neuropathic pain, and just kind of monitor to see if they tolerate it, right? So it's always kind of safer to, like if you're starting something new, especially they haven't not been on it before, so we don't know how they're gonna react to the medication, if they're gonna develop ADE and they have risk of drug interaction and increased risk of exposure, then you can start at lower dose and titrate up, and you can still monitor, right? So those are some like thought process that can go, into like starting selecting like a dose for medications. As for clinical pearls, I guess it's related to the insulin, your adjusting medication doses if there is like DDI, also the duloxetine as well, starting the dose in terms of, weighing the benefit versus risk. I want you guys to start kind of thinking the bigger picture, right? I know like there's a lot of things going on for this case, but again, like at the end, right, you're not just treating one problem. A lot of patients, that you will see, they'll have a lot of problems with them, right? So when you're adjusting medications, you're recommending doses in the inpatient setting, think about what's already been, what information's out there that's been given for you. So for example, the insulin, right? I heard some students were recommending using the insulin basal bolus protocol. And then, based on the criteria, the insulin they take at home, the weight and everything else, the patient fit the criteria to start the 0.5 units per kilogram per hour. I mean, 0.5 units per kilogram per day. So that, sum up to be, about 44 units of insulin total, which include basal and also the mealtime insulin to 44 units per day. So if you think about it, right, 40 units, if you use the insulin basal bolus protocol, and when you compare it to the home dose, which is insulin MPH 40 units BID, so that's like almost double what you're going to be recommending if you use the insulin basal bolus protocol, right? And now let's take a look at how the patient is doing with the insulin MPH 40 units BID. When during presentation, like even though she's compliant with the insulin at home, the glucose is still 200s, right? And what do we say about the goal that we want her to be at in patients? 140 to 180, right? So do you think starting her on the 0.5 units per kilogram per day will touch her? I would probably say no, right? Because it's almost double, right? Like double, 100% more of what you're giving her. So, even if you're worried about hypoglycemia, they're not stable, adjustment wise, it shouldn't be, 50%, right? Like, and the patient coming in with like hyperglycemia, right, on that insulin dose at home. And like if you look at the timeline, the patients did get hypoglycemia, but it's because she's getting 80 units of insulin glargine, right? Which is double the dose from home, which is double the dose of the 0.5 units per kilogram per day. But if you look at the insulin conversion guide, you shouldn't be, converting the BID dosing of the NPH by 1:1, right? If you look at the guidelines, you should reduce it by 20%, right? So that's why they're probably getting the hypoglycemia, right? And the reason why, like if you're changing for some insulin that's dose BID to like once daily, especially for the long acting or the intermediate acting, you want to be careful, right? Because they are getting the insulin more distributively with the NPH because they're getting it twice daily, right? Instead of just getting one big chunk of the dose for one time. But again, you have to kind of consider too in terms of what is appropriate in terms of dose, right? Starting at lower dose, 64, maybe even like reducing it further to like 50 or something like that. It might be okay, but I feel like if you reduce the dose equivalency more than 50%, I don't know, like it's probably not going to do anything for the patients. And if you're not controlling the blood glucose while in the inpatient setting, if it's like more than 180, it does increase the risk of morbidity and mortality for the patient. So that's kind of like another thing to kind of weigh the benefits versus risk. And then for the other, I think, bigger picture thing I want to mention is the DDI with the statin and also the QVAR. I know like a lot of students recommend those too. So the statin, per the patient's risk factor for ACVD, definitely the patient needs to be on high intensity statin, right? So that's at least something that you need to recognize for this patient, right? You don't want to just adjust the dose just because there's interaction, but you also want to make sure that they're going to be optimal on the adjusted dose as well, right? So yes, the patient is going to be on, they need high intensity statin, but then because of the interaction, they need a lower dose just because, there's increased exposure, like multiple folds of the exposure. So reducing it to the max dose is going to be, the first thing that you do, right? Because they need the benefit of the the statin, right? Equivalency, high intensity, but adjusted to the drug-drug interaction recommendation. So 20, it's the max that the guidelines, the HIV guideline recommended. So that would probably where I will go. I wouldn't go higher than 40 just because it's not recommended, and lower, it's possible, but I feel like there's a risk associated with unoptimal statin, right? So in this case, if you are not optimal on your statin, you can get heart attack, right? And then you can monitor the statin, for muscle pain. And she's been on statin for a long time. I am not very worried. She's not like high risk patients for muscle pain, or abdomyolysis. She's not very, very old. Like, she's not older than 65 years old. And she never have any incidents of like muscle pain or anything like that before. So I would be okay in like having her on like the max dose of statin, adjusted to the DDI with antiretroviral therapy, and just kind of monitor the patients. Okay. And last clinical course I want to share, which I think a lot of students are doing a good job in this case, is the blood pressure and the blood glucose. Kind of just something I want to share, like in acute illness setting, especially infections, your physical, your body is going to be on a lot of physical stress, right? A lot of stuff happening. Your body's trying to survive, fight the infection. So your body is going to, it's going to be inflamed, and that can, cause a lot of steroid production, right? When your physical body, or your body is physical stress. And what is the side effect? One of the side effects of the steroids, it can increase blood glucose in your body, right? So that's why, like, when somebody is diabetic and then they have a little, infection, acute illness, the blood glucose might be elevated. And it is much, much more important to kind of control it, right? To make sure we're putting it, controlling it to target goal of 144, 180, because the more sugar you have, the worse, the patients will, again, elevated blood glucose in the inpatient setting is associated with a lot of risk factors, a lot of morbidity, mortality. So you want to make sure they're at target goal of 140, 180 while we are managing the acute illness or infection. And the more blood glucose you have, the more it's going to feed the bacteria or fungal or whatever microorganism you're trying to get rid of, right? Because that's their fuels, glucose is our fuels as well as a human being, as a microorganism. So just something to share, and maybe you will see it, in the inpatient setting once you get to your internal medicine rotations, and you can kind of see, the trend of the blood glucose in the inpatient setting when they're very, very ill, having infections, have a diabetes history, blood pressure as well. When your body is in physical stress, they're trying to survive, they're going to be on a lot of stress, producing a lot of steroids, and that can in turn increase your blood pressure, your heart rate. You're going to be hyperreactive to fight the infection or fight the illness. So one thing, I think one of the OB question we're asking you, what are you going to do with the blood pressure while in the inpatient setting? So I am very happy to hear that, a lot of you guys are thinking about, like the illness causing the high blood pressure. So like maybe for now, we can kind of sort of just continue whatever medication they're on at home, and then just wait, monitor to make sure, the blood pressure doesn't drastically go down, right? When they're sick, it's easier for patients who get in shock to go into hypertension. So we, rather than jumping in the gun to add another medication for the blood pressure, let's kind of monitor it, hold for a second. Unless you have a baseline, like unless they kind of bring their blood pressure log from home and then it was persistently elevated, persistently over the goal, then yeah, maybe you can kind of start thinking about adding other medications. But if they're, you don't have a baseline, we don't know where they typically stand when there's no acute illness, then I would kind of monitor first, see what the trend is for the blood pressure, and then make a decisions once we have more information, right, for the blood pressure. Um, I think a lot of times when patients coming in with 130, 140, I'm still okay with it, when they have acute illness, because I know it's probably because of the sickness. And then, once we treat at least give them a little bit of relief from the sickness, or like, their symptom relief, their blood pressure, you might see that they going to trend down, not being persistently high as much. But like you might kind of consider adding, if their blood pressure, from the beginning, from the get-go, like it's about like 150, 160, then it's a little bit higher, like especially if they have like a lot of risk for, or complication risk, like stroke, ACVD, and everything else, like high blood pressure. I would probably be a little bit more cautious. um, but trying to keep kind of like, consider all the risks, all the benefit, making sure we kind of see the patients in the bigger picture. All right, and that's pretty much it for the debrief for case 3. um and one of the announcement I have for this week, I'm still looking for liaisons from Dr. Guerrero and Dr. Young section. So if you guys have the time, again, like the time commitment is not a lot that I'm asking from you guys. It's just um, one meeting, about an hour, 30 to like 16 minutes, depending on what, how much discussion we have. And it's going to be next week, actually on June 7th during class time and doing CB4. And just kind of like, be the ear and eye of your classmates, advocate, if they have any feedback, you can kind of share it during the discussions or email me straight. All right. Thank you. And we'll see you in about 2 weeks.